The topic is psoriasis. Have you heard of psoriasis before? So it is a papilloscomus disorder. It is a keratinization disorder. So there is a layer called keratin in our skin. So basically, the thing is that in this disease, the life cycle of the skin decreases and it becomes dead skin and it turns into scales very fast. Basically, when the skin is formed, it takes the life cycle of a skin is like the skin cells basically the keratinocytes are around 50 to 60 days, but in this condition it is 3 to 5 days. So when the keratinocytes are formed in the skin, so if you know the layers anatomy of the skin, so basically there are 3 layers. So but in the epidermis there is another 4 layers. So the keratinocytes are present in the epidermis. So what it originates and then becomes dead within 3 to 5 days and it becomes scales. So basically this is an autoimmune disorder, this chronic condition. It till date there is no permanent cure for this. So there is no permanent treatment. You can just manage the condition, but you cannot totally treat the condition because it is basically multifactorial. So there are many factors: genetic, environmental, drugs, infections. So there are many multifactorial causes which leads to psoriasis formation. So that's why there is no particular proper permanent treatment for this condition. So that's why this is a very common skin conditions we will see in the OPDs. So patients will come, you will give the treatment again, you will treat it, it will go back again, it can come. So counseling before the actual treatment, proper counseling is very required in this kind of patients. So whenever you see psoriasis in OPD, psoriasis very commonly if you do medicine, MBBS, derma, obviously psoriasis is your subject, but psoriasis is commonly, it's one of the common skin conditions in the OPDs. So another fact is that somebody has dandruff, but it doesn't get resolved with normal anti-dandruff. But basically that is sometimes it is misdiagnosed as dandruff, but it is scalp psoriasis. So again it comes back. It is more thickened. So I'll come in later. So it is the word derived from Greek called psora, means itching. So it is a chronic, non-infectious. It is not a non-infectious, but infections can trigger. So it's an inflammatory skin condition in which the epidermal cells are produced at a rate that is about 6 to 9 times faster than the normal. So the lifespan of the epidermal cells gets reduced. So it originates and becomes dead, but it doesn't fall off generally. So that's why it becomes it adheres and becomes a thick scale. So this is called psoriasis vulgaris. So this is the type of you commonly see. So the cells in the basal layer of the skin divide too quickly and newly formed cells move so rapidly to the skin surface that they become evident as profuse scales or plaques of epidermal tissue. That's what I was saying, that it originates and comes to the upper layer so fast and it becomes dead. So the psoriatic epidermal cell may travel from the basal layer. So basically there are 4 layers in the epidermis. So it comes, basal layer is the lowermost layer. So stratum corneum is the most uppermost layer. So it comes generally the lifespan is like 28 days, 30, even 50, 60 days. That is the normal. But it comes within 3 to 4 days. That's why it becomes scales. So etiology is mostly idiopathic, but the triggering factors are like genetic, autoimmune, infection, injury to the skin, and changes in climate. So mostly we see in psoriasis aggravates in winter. Basically it's a dry scale condition. So an injury to the skin, so another phenomenon you see, coagulation. Coagulation also comes in MCQs, in which like you will get which of the following skin conditions shows coagulation, except in that way you will get MCQs. So medications like lithium, people on psychiatric drugs like lithium, antimalarial medications, propranolol, indomethacin. Stress is very important. Stress also contributes for psoriasis, obesity and smoking. So what is the pathophysiology? Etiological factors which I have discussed before. The skin in the patches of psoriasis is growing much faster than the normal skin. Rapid production of epidermal cells which does not allow the cells to manufacture keratin that gives its hard surface. So that's why you see flaking and patches of skin. So clinically, the first sign of psoriasis is often red spots, which you have seen in the picture, red spots on the body. Then it becomes dry, swollen and inflamed, that is erythematous. Patches covered with silvery-white flakes, that is also we call scales. Raised and thick skin, and these are the characteristics of psoriatic skin. And other symptoms of psoriasis includes pain, itching and burning sensation. So what are the other skin manifestations like restricted joint motion and pain? So another chronic psoriatic skin condition can lead to psoriatic arthritis. That is very rare, but there is a condition called psoriatic arthritis. So even the joints can also involved. Cracked and bleeding skin, dandruff on scalp. So basically it's scalp psoriasis. Pus filled with blisters. Sometimes these are rare. These are not for at your level, but sometimes psoriasis can cause blister-like lesions. So that's we call pustular psoriasis. It looks like infection, but it is not infection. It is pustular psoriasis. Genital lesions in males, pitting and small depression on the surface of the nail, yellow and discolored nail, and arthritis, which I said. So basically I am discussing more about psoriasis vulgaris, which is most common. 70 to 80% of the psoriasis we see is psoriasis vulgaris. So the lesions are most abundant over scalp, extensor surface of the elbows and knees. So basically characteristic of psoriasis is the extensor area. Okay, so not the flexible areas, mostly the extensor like knees, so knees, elbows, knuckles. Okay. So these are the where bony prominence is more, there we see psoriasis. Then palmoplantar psoriasis, we see palms and soles. Bilateral symmetry is a feature of psoriasis. Basically psoriasis is symmetry. The character is symmetry. So both sides of the body is involved, not unilateral. In approximately 1/4 to 1/2 of patients, there is a psoriatic nail condition. Nails are involved with pitting, discoloration, crumbling beneath the free edges and separation of nail plate. When psoriasis occurs on the palms and soles, it can be called pustulations called palmoplantar psoriasis. So these are the most common sites we see. So if genitals and there is another pattern is inverse psoriasis where flexors are involved, like armpits, this side, the flexural side of the elbow, then genital area, inguinal area. So these are rare rare types of psoriasis called inverse psoriasis. So diagnosis and how to diagnose. So basically it is clinical, mostly it is clinical, but we do the history and do a skin biopsy. For psoriatic arthritis we do radiography test and ESR and C-reactive protein. So what are the goals for the management? What are the goals? Basically to slow the rapid turnover immunity. So we cannot totally treat the disease, but we can reduce the progression of the disease. To slow the rapid turnover of epidermis, to promote resolution of the psoriatic lesions, to control the natural cycles of the disease. So basically there is no cure. So basically we are controlling, just controlling the disease. You cannot totally cure the disease. So basically first, to avoid any aggravating factors, precipitating factors, assessment of lifestyle because it is significantly affected by stress. Now we come to the treatment modalities. So there is topical therapy, there is intralesional therapy, there is systemic therapy, there is photochemotherapy. So depending on the severity and depending on the extension of involvement, we choose this kind of moisturization. If it is local focused, then we mostly give topical or intralesional. When it is covering most parts of the body, like we use the body surface area calculation. So more than 10 to 20% we give systemic. So BSA, like we calculate in BSA. Okay, another called is PASI. So PASI score that is not at your level. So body surface, depending on the body surface area, we give the we choose the systemic or the topical. So topical, most important is gentle removal of scales. This can be accomplished by doing bath. Okay. Then oils and cold tub preparations are used. Then basically moisturization is very important. We use emollient creams. Then we give salicylic acid. Salicylic acid is like it will remove the excess keratin. So it is a keratolytic agent. So cold tar preparations are we use, but side effects are photosensitization, and also in scalp psoriasis we use tar shampoo, occlusive dressing. These are old technique. Anthraline creams, then topicals, corticosteroids. Mostly we use mostly topical corticosteroids for short periods because there are side effects. So these are the most common preparations we use, but mostly we use the topical corticosteroids. Intralesional therapy, like we use intralesional corticosteroid therapy. Then systemic therapy, we use methotrexate, which is the most common systemic drug we use. So it basically acts by inhibiting the DNA synthesis in epidermal cells and thus by reducing the epidermopoiesis. So we should monitor before giving methotrexate. We should monitor the blood profile. We should see the liver function test, complete blood count we should do. So all the hepatic, hematopoietic and renal systems should be normal before giving methotrexate, because it is a cytotoxic drug. Okay, basically it was used, it is still used as an anti-cancer therapy. So, but it is a cytotoxic drug. So it reduces the immune system. So chronic use of methotrexate can lead to other infections. You are prone to infections, but it is dose dependent. So basically, we should monitor the blood parameters and the systemic parameters before giving methotrexate, and also see that patient have not suffered tuberculosis, because if patient is suffering or have suffered from TB, then methotrexate can reactivate the TB. So, and we should not give in women who are about to become pregnant or planning for pregnancy or during pregnancy or during childbearing age. Basically it causes abortion. So methotrexate is an abortive agent. So we should not give in. We should, before giving to any young female, we should take proper history that whether she is married or not, or she is going to get, she is planning for pregnancy or she is pregnant. So this is category X. So methotrexate for any purpose, if you give, first see female or male, and female especially take history about pregnancy. Very important. If you give methotrexate in a pregnant woman without taking history, then if the child gets abort, then you will be in jail. Okay, so, and methotrexate is a very toxic drug, so it is dose dependent. So you should, before prescribing, you should be very careful while writing methotrexate, because if you become, methotrexate is not only used in skin, it is used also in rheumatological diseases like arthritis also. Okay, so if, for any osteoarthritis, arthritis, rheumatoid arthritis, so MBBS, even if you do general practice, methotrexate is required. So before giving prescribing methotrexate, be careful, take proper history, do blood investigations, and check whether, and especially giving in childbearing age women, you should take proper history. So oral retinoids, same. Oral retinoids like vitamin A derivative. So basically use acitretin, is a oral retinoids. This is also it doesn't act like psoriasis, it's methotrexate. It acts in a different way, but same. It is also category X drug, teratogenic. If do not give to pregnant women, do not give to pregnant women, and also women planning for pregnancy. Okay, so if you give retinoids in a pregnant woman, you have to tell the patient, if the patient takes any oral retinoid during pregnancy, she has to abort. She has to abort the patient, because the patient there will be limb defects. The baby will born with limb defects. Okay, so do not give oral retinoids during pregnancy. So hydroxyurea we do not use, cyclosporine A we use. For giving cyclosporine, we should also see renal status, urea creatinine, and blood pressure. So cyclosporine increases the blood pressure. So another treatment we do is photochemotherapy. We use Soralin ultraviolet A therapy. Here we use 8-methoxysoralin, and basically the patient has to take the drug and sit in the sunlight or in a UVA or UVB chamber. So you use the ultraviolet A and B wavelengths to treat psoriasis. So this is called photochemotherapy. So it is one of the ways, and also completely safer than other alternatives. Ultraviolet B light is also used to treat psoriasis. Is more safer than UVA, because UVA causes more skin damage and leads more chance of skin cancer than UVB. So complications, patients suffering from complications can have infections because of the treatment, fluid and electrolyte imbalance. So there is a condition called psoriatic erythroderma. So if more than 90% of body is involved, so it causes transepidermal water loss and can go into shock or electrolyte disbalance. So lot of fluid and protein loss occurs in psoriasis patients having more than 80 to 90% involvement. So in psychological factor, it decreases the self-esteem of the patient, always in depression, why it is not getting treated, why there is no permanent cure, why there is basically why I am suffering. Questions will come that amari keno hocche, keno eta treatment nei. So basically patient go into depression and low self-esteem. It also hampers their work life, and every time taking medications, always on medications. So counseling is very important, and proper counseling and psychological therapy is also required for psoriasis. So depression, stress, and also as it is an inflammatory disease, it causes metabolic syndrome. So like increased blood pressure, high blood sugar levels, excess body fat, abnormal cholesterol levels. So now it is not only local disease, not a specific skin disease. Psoriasis can also be, it is also a systemic problem. Hypertension, joint damage, these are the complications or comorbidities we say. Okay, so this is the short for, it's a very huge topic. So this is a big books on psoriasis only, but for at your level, just this much is enough for your short notes.